Yeah.
They'll be great. Yeah, they'll be find that.
Oh, it's awesome.
Like everything else, yes, I'm gonna have, I don't know which one.
It does smell weird.
Yeah.
This 401, so we will start. Welcome everybody to the August session of Grand Rounds. Today we have the pleasure of hosting Dr. Maike. Dr. Maike is a nephrologist and he completed all his training at FMLH, starting from medical school and through nephrology fellowship. And he's now an assistant professor of medicine and the medical director of Inpatient Renal Replacement Therapies at Frederick, and also the associate program director in the nephrology fellowship. And today he will talk to us about kidney stones.
Thank you everyone for having me. Like Dr. Mercier said, I'm Andrew Maike. I'm one of the nephrologists both here and at the VA. So I've seen a lot of your names on the charts, and a lot of you have even taught me back when I was a med student. So it's good to see you again. I practice most of my clinics are at the VA. I have one clinic a week here, and I also go to the Green Bay VA clinic. So any of you guys at the VA, if you have patients, I also see patients at the Green Bay clinic. So I'm split my time all over the state. So financial disclosures, I don't have any financial disclosures for this presentation. As the medical director of dialysis here, part of my compensation is through Fresenius, but we're not going to be talking about dialysis today. So don't worry, no huge chemistry lessons. So that'll be good. So some of our objectives today, we'll review the pathophysiology of nephrolithiasis. We're going to discuss mainly stone prevention strategies that we use in clinic, and then some of the dietary roles that we see in hypercalciuria. I figured these were the most important that you wanted to talk to me about or hear about, since we see a lot of hypercalciuric patients come from the endocrinology clinics, and how we as the nephrologists help manage that to help prevent kidney stones. So a lot of this will come from Dr. Wesson's materials. He's been teaching this for decades. He's starting to slowly hand his responsibility over. So in the next couple years, I'll probably be taking over as the medical director of the kidney stone clinic as well. So a lot of these slides were from him and a lot of the data that he's collected over probably 30 years. So I learned from him when I was a med student. I started in his clinic, and now he's my mentor and colleague. So we'll get started. And please, anyone, if you have a question, just let me know, raise your hand. I'm happy to answer anything. I also brought some pamphlets so you can pass them around when I'm talking. These are our pamphlets that we hand out to all the stone patients. I brought all of them. But you guys are mostly interested in the calcium-based stone, so I brought all the data. So you can pass those around while I'm talking. So starting with a case, this is a patient that I saw earlier this year. So he's a 36-year-old gentleman. He just moved from Florida up to the Wisconsin area. He has a history of mood disorder, nephrolithiasis, quote, post-COVID issues, mainly GI, but he did have some cardiac problems with that. But the post-COVID, he had limited dairy intake. He was taking high levels of Tums as well as other supplements. So he started having more stones than he usually did. But his stones started all the way in 2006. He was unable to say how many, but his last surgery was in 2020. So these are things that we always have in our consults just to let us know how many stones people are actually making and when the surgeries have been. So his last stone passed about 6 months on his own, and he did not need a surgery for that. And his previous recommendations from Dr. Wesson, because he was actually following up from Dr. Wesson's clinic into my clinic. He just knew he wasn't supposed to take as many Tums because of the GI issues. However, in talking with him, he's had many different people see him, Florida and other states, and then he wanted to come and see me for how I could help him with his stone prevention. So his main thing was that he presented to me, he knew how many Tums he should not be taking. So this is a typical urine study. We'll go through this, but this is the big, I hope it's big enough on the small screen so everyone can see. But this is what we're looking at. This is the litholinks test that we get here at the Frater Hospital. The VA has a very similar one. It's called the EuroRisk. It's pretty much the same data, but some of the numbers and reference numbers are a little bit different. But you can see in his, and I just need to look at the pointer. So this was his actual first urine that he had right before he saw Dr. Wesson. So we can see main focuses are, and not all the bad things are in yellow, but the biggest thing we focus on is urine volume. Pointed them out. We have our risk factors that we'll talk about. His calcium was pretty high in the urine at that point when he saw Dr. Wesson. His citrate was low. You can see his sodium was pretty high in the urine. And then this is the PCR litholink is actually looking at protein intake. And we'll talk about that a lot today. But these are the main things that I focus on. But for a lot of the hypercalciuric patients, this one's pretty high, but we'll see them in the 300 to 400 range. But these are typically the patients you're sending us with the high calcium. So he definitely had hypercalciuria and was having a lot of stone burden.
Something
Yeah.
quick. Is this covered by the insurance? Because I recently got some pop-up messages.
So you'll get the pop-up. I'm not sure. Did the pop-up say it'll cost them between $500 and $700? Yes. I'm not sure how much it's actually billed. The hard thing with this is it used to go through Frater to now when we order it, and that's, I think if we order it, it might be covered differently. Our nurses send it in our name. We'll go, that's one change that we implemented this year. But I'm not sure how much is actually billed to the patient. So I try not to get a lot of them because I really don't know how much they are, but it does pop up with that very expensive mark. But it's a lot of data. What they do is they send it out to a third party. I think it's in Colorado for the litholink, and they do all the litholinks in the US. So it does take some time and it is expensive because it's third party. So for some background information on kidney stones, so these are some stone pictures. Obviously, they can come in different sizes, shapes. Some patients pass very small stones very frequently. Some can just make very large stones and they need them surgically removed. But they come in different shapes. This one has a little blood tinge to it, so it was taken out. For some reason, it went forward. But some of my patients will bring in bags of stones every time I see them every year. Some will just pass them at home and call us. So looking at kidney stones, it's been a major health issue. The earliest occurrence was found in Egypt in the manuscripts of about 5000 BC. There's a couple people that are pretty famous that have known to have kidney stones. They can become pretty large, so that's a quarter, so very large stones can form. And we'll talk about 10% of the population. They're made up of multiple different entities and compounds, and they come in many different shapes so that we can see staghorn shape, jagged, smooth. Typically, the surgeons will see them. I never see them unless a patient is actually able to bring it in a bag. And obviously, they cause pretty high morbidity just because of the pain, the recurrent need for procedures. They see a lot of specialists, and I think a lot of my patients fear about having their neck stone, and that's why they keep following up with us to help prevent the stone formations. So a little bit about the epidemiology, like I said, the lifetime prevalence is about 5 to 15% in the United States, and that's actually been going up. The data shows annual incidence is about 1 per 1,000. The demographics, look at them. So we typically see more men in our clinics than females. White race, more commonly affected in the data. The peak incidence is around middle age, but I see people in my clinic of all ages. And I hear of a lot of patients with them. So I typically will see 20-some, even up to 80s in my clinic for stone prevention. There's some substantial regional variations, which I'll show some data on. And then the recurrence rate is about 50% in 5 years. So when I see patients, I'll usually tell them the average stone former, and about every 7 years you'll have a stone. But I explain the average. Sometimes I have patients having bags of stones every time they see me. Sometimes it's every 20 years. So it can vary very differently in patients. And it's a very rare cause of ESRD in most cases. Sometimes the reason why people might become ESRD with these, if they become septic and need to have surgeries, that's when I've seen it. But it's generally in the genetic stone formers who have been forming them since childbirth, and they've had stones since they were children, and they can repeatedly have them and cause ESRD. But the other situations we worry about, obviously, are transplant patients. They can have stones form in the transplant. It gives them hydronephrosis, and then the kidney transplant fails. So I see a lot of transplant patients to help prevent stones, solitary kidney patients, and then obviously the genetic stone formers. So this graph is showing us the regional variations. So this was from 1989, but this was one of the Mandel group that I think used to work here, but was very close to Dr. Wesson. They might have been at the VA.
They were at the VA. They were at the VA.
Yeah. So it shows the regional variation. A lot of times in the hotter, warmer regions, we're starting to see we do see more stone formation. But that's typically the areas that we see the most. But it happens everywhere. It's going automatically. So the stone prevalence is increasing, like I said, in all the ages. So in all ages, stones are going up. Stone formation is going up in males, in females, in white compared to black. So this was N. Haynes data that was pulled into the early 2000s. So the typical stone composition distribution, so this was from our actual stone clinic data at MCW. I'm not sure when it was pulled from Dr. Wesson's data, but obviously the most we see is the calcium oxalate, which is the most common type of stone. Then we see calcium phosphate. These are typically the stone formers that you guys are sending us, but we also see a good amount of uric acid stone formation, the struvite or the infectious-based stones, and then way over here, the cystine-based stones. That's the most common genetic. It's very rare. Maybe you see a couple in your lifetime. I talked to Dr. Wesson, he's seen 2 or 3, but they form many stones and they can go into renal failure because of the cystine composition in the kidney. But the most common types that we see are the oxalate and phosphorus. So the pathophysiology of kidney stones. So there's still a lot of research going on in this. It's a very old disease, but we still don't know exactly what causes kidney stones. Some of the current thoughts and what the research is in right now is the supersaturation of the urine with all the chemical compounds. A lot of places are looking into modifying risk factors primarily, so how we can prevent stones through risk factors. That's how my clinic runs typically, and we'll talk a lot about this today. And then urine proteomics, which is a very large word. This is actually Dr. Wesson's group, and he's looking at protein folding structures in the actual urine to see if that causes kidney stones. He has a PhD in molecular chemistry, so he is very good at proteomics. I will not be talking about his research today. It's very difficult to understand. But mostly it's the saturation of ionic concentrations. So a little bit, the pathophysiology continued. So crystal formation forms in supersaturated urine. So this is ions or any molecular compound and very high concentration in the urine. and we start forming crystals, and the crystals enlarge. The urine pH plays a very big role. So depending on the acidity of the urine, these crystals can form larger and larger, and then we see stone formation. Then we think that the crystals adhere in the papilla, which is Randall's plaque, which is just a small spot in the kidney that the kidney stone adheres to. So over time, crystals aggregate together over many events, and then the stones become larger and larger. We can see them radiographically then. And then at some point, they don't know when or why, but the stone breaks off the epithelium and descends down the urologic tract. And that's what causes all the pain and morbidity with the disease. So this is a scanning electron microscope of a stone. So you can see over time all the crystallization, and it's just forming layers of stone upon layers, and then the stones enlarge. And this one comes up a little better. And these are more scanning electrons pictures where you can just see the palisades of all the crystals lying down on each other, and then the stones enlarge over time. So this is just a graph of showing the stone formation. So coming down the urinary tubules, we have all these ions that are being exchanged throughout the entire kidney. Ions mixed with proteins that are typically in the urine. They form aggregates. So the crystals become larger and larger. They adhere to what we think is the Randall's plaque. The stones continue to enlarge over time, and then they break off and then cause all the pain. So these are some of the urinary crystals that we can see. I'm not sure if they're students or residents, but these are typically on all the boards exams, and they're on all of ours. Most common type are the calcium oxalate crystals. They come in two forms. So we have the monohydrate and the dihydrate. But what we see are these dumbbell formations with calcium oxalate. That's just, we caught some in the cross section. And then the dihydrate looks like a folded envelope. So a lot of times this is what we see on urine microscopy. The other ones, so the cysteine, the hexagonal shape, these are the very rare crystals, but that's what they look like. Uric acid are the rhomboid crystals that are birefringent under our microscopy. These are the phosphate. They kind of just look jagged edged. And then the struvite that we all remember are the ones that look like the coffin stones. Those are from the infectious causes. So I've seen them, but very rare. The most common type we see in the hospital are the calcium oxalate type crystals and uric acid. And then these are the less common crystals that we see. So drugs and metabolites of drugs can actually form stones. So the biggest ones are like sulfamethoxazole, ciprofloxacin, a lot of the guaifenesin now. If people are taking a lot of guaifenesin, we've seen crystals and stones form, and almost like a sludge in the urine even, if you take enough. So drugs can form crystals. And then acyclovir, Dr. Wesson gave me the insight. I've only seen this a couple of times. We don't use acyclovir in the hospital as much as we did during the AIDS epidemic and everything, but very high doses of acyclovir cause these needle type structures, but that's typically on boards too. So a little bit about hypercalciuria. So typically described as urinary calcium excretion over 275 milligrams in men and 250 in women. It causes about 80% of the stones. So our calcium based, and looking at the data from our institution, we're right around there. High urine calcium is the single most common abnormality of the urine chemistry in our recurrent stone formers. And that's why we follow the chronic litholinks to see how we can affect the diet and change how much calcium is in the urine. And then if we remember back, serum calcium is freely filtered in the glomeruli. 60% is reabsorbed in the proximal tubule. That's driven by water and sodium. And the rest is absorbed in the thick ascending loop of Henle, and that's more pH driven along with magnesium. I think that's the most glomeruli and nephrology talk I have today. So that's good. So idiopathic hypercalciuria, so they describe it as a genetic mutation or a modification in the the calcium reabsorption pathways. So we can have absorptive, which is the increased intestinal calcium absorption. We have renal calcium leak, which is inherent in, which is an inherent kidney problem. So we can see proteins in the urine, proteinuria, or the renal tubular acidosis. We see calcium leak. Some drugs can cause it as well. Resorptive, as in hyperparathyroidism. And then we have renal phosphate leak causing hypercalciuria. So nephrocalcinosis is typically what we call when we see a lot of calcium deposition in the kidney. Typically, we aren't biopsying these people. Sometimes we have kidney stones that they need to take part of a kidney out. So you could see that on microscopy then. But you can see over time with hypercalciuria, the ion or calcium ions are being placed into the tubules. They line the tubules. And over time, that can cause renal damage. So we can actually see this on our imaging and help diagnose calcium problems. So the Stone Clinic at MCW, so we have myself, Dr. Wesson, and Dr. Dahl see most of the kidney stone patients here. Like I said, I think Dr. Wesson has 2 clinics a month right now. I'm seeing stone patients every Monday, and Dr. Dahl has them sprinkled in his 3 clinics here. But primarily it's myself and Dr. Wesson right now. And then the urologist, Dr. Davis, is our stone doctor both here and at the VA. So we work very closely with each other to help kidney stone prevention. So the multi-specialty role, so these patients will typically see us once a year, the urologist and ourselves. So we help manage the serum and urine metabolics through all of our chemistry testing. So that's our main role. Urology will follow the patient just for stone monitoring and any surgical or procedural needs. And they also monitor for stone growth. The nephrologists typically do as well. And then I put in endocrinology because a lot of our paths meet if there's a parathyroid or a bone disorder. So these are the specialties that are typically managing them. And I think our common goal is to decrease the frequency of stone formation and the size of the stones. I like to tell my patients, I'm not going to be able to stop all of your stones, but my goal is to keep them small enough that they'll actually pass on their own so you don't need surgery, or that we can get them to space out. If you make a stone every 2 years, hopefully I can push that out farther and farther so we don't have as many procedures. So this is my typical stone prevention consult. So there's a theory that there's a lot of theories in stones formation, like I said, but I think it all mixes with your genetic history and your past medical history, your physiologic or what's going on with you right now, and then your diet. And if these mix together just right, you'll make a stone. And then this can continue to happen. So we're trying to break some of this just to try to see if we can prevent kidney stones. So a lot of this is just long history taking. If you read my notes, it's all bullet pointed. So I can go back and look in to see, well, did something change, or did they change something in their diet that we need to talk about this year? So for the genetic component, so I always ask about family history of any renal disease or nephrolithiasis, just to see if everyone in the family is making stones, it can clue me into is there a genetic abnormality. So cystinuria, like I said, very rare, but these stone formers are making a lot of stones every year. The primary hyperoxalosis, you'll typically just see calcium oxalate stones. They start making them at very young age, and then they generally go into renal failure very early. So the treatment is actually a liver transplant. but we very rarely see these. Dense disease, which is leakage of small proteins typically seen in males. And over time, it causes calcium leak and nephrocalcinosis and recurrent nephrolithiasis from a young age. Familial hypomagnesemia and hypercalcemia. So we typically see calcium crystals, phosphate, and oxalate. Hereditary rickets, and then renal tubular acidosis will cause calcium stones as well. So a lot of my time I talk about the past medical history. I like to know all the medications the patient's been on within the last couple of years, just to see if that could have caused something. The big thing with why I ask about hypertension is a lot of our treatment or some of our treatment modalities can lower the blood pressure. And typically the patients I see the most are females that are very active, and the blood pressure is starting around 100 or 110 at baseline. So if I put them on the thiazides, I'm going to drop their blood pressure and they're going to become orthostatic. So I ask about orthostatic symptoms right away. If they take their home blood pressure, or I go back and look at where their blood pressures have been in clinics, I think that's important. And I always warn them about the risks of treating with the thiazides. And then the other big medical things that I watch out for. So inflammatory bowel disease or short gut. This will cause a change in how the calcium and oxalate is absorbed. That's the theory, and then we can see a lot of stones after that. So I like to ask about any GI issues. Obviously, I look and see if they've been seen by one of you guys, if they have hyperparathyroidism or any signs. Why would they be hypercalcemic? So we look into if there's a cancer or sarcoid. One of my first patients I saw as an attending at the VA when I graduated kept getting admitted for kidney stones, had calcium everywhere, and we actually found out after a couple months she had sarcoid. So after she got treated for sarcoid, her renal failure or her CKD went back to about, her creatinine was up to 5, and then it went down to 1.1 after we were able to get the calcium under control. So we see a lot of patients like this. Gout, obviously for uric acid crystal formation, so I always like to ask about gout. Bariatric surgery is another thing that I've been seeing a lot more patients with. It's the surgery itself can change the way we absorb the molecules, but also the diet after the bariatric surgery can put you at high risk for stones. So a lot of patients aren't aware of this when they have the procedure done, and then a couple years later they're in my clinic asking what's going on, and I have to tell them that it's the weight loss surgery that probably caused it. And then I put in pregnancy. We do see a lot of stones after pregnancy. The thought is that the prostaglandin release can kind of not weaken, but loosen up the ureters to allow urine stasis, and then stones can form. Another thing is people do chew a lot of Tums during pregnancy, and that can cause an increase in calcium in the urine, as well as change in diet. So we've seen some, and my sister-in-law called me because she had a stone right after giving birth, and she had changed her diet a lot and had her first stone. So we look at all the risk factors. We can't mitigate a lot of these, but it gives us a hint as to what could have caused the stones. And then certain drugs that I look out for. So the biggest ones, topiramate, acetazolamide, these are the drugs that can put you at high risk for stones. So I see a lot of patients with them. The issue is a lot of times we can't be taken off if they're for seizures. So we just have to work around and try to fix the urine chemistry. The big one right now, I'm seeing a lot of vitamin C use. So that vitamin C breaks primarily into oxalate and breaks down so that we can see renal failure from that or a lot of stones. So I saw a very big increase in patients during the COVID epidemic. We were told to take a lot of vitamin D, a lot of calcium, and pound vitamin C tablets. And with that mixed together, it caused my stone formers to increase the amount of stones they made, and it made a lot of new first stone formers. So I try to look for that. And then ethylene glycol obviously can make calcium oxalate stones. That's what we like to learn about in med school. Typically people aren't taking this, but it's something that we see in the hospital. and poisonings. So that's a thing that we look for. We used to use the Merrick protocol here at the at Freighter, which was I think 10,000 units of vitamin C Q6 for refractory shock in the CVICU, and we ended up seeing a lot of people go into renal failure for that. So that's why we stopped using that. But that's another thing we watch for is high dose vitamin C, and it's many case reports have been published. I published one from fellowship, so I really watch out for vitamin C. So then we get into physiologic component. So this is where I take seeing what they're doing. So employment, I think, is the biggest thing. So I tier them into the like risk tiers. So my first highest tier are usually airline pilots, bus drivers, or long haul truckers. These people will dehydrate themselves on purpose so they don't have to stop and urinate. The biggest thing that I tell them is they have CDL, so they will get pulled if they have a lot of stone disease. So I really watch for these guys. The second tier I usually see are like doctors, nurses, teachers, because we dehydrate ourselves to get our job done, and then within a couple years, sometimes we can see stones. And teachers are getting up there now. I think they get less breaks and they can't drink enough water. So I ask about that. And then the third tier we usually see like welders. I have a lot of masons that no matter how much they drink, they're losing so much volume of fluid through sweat. And the welders, especially because they're in heavy gear, that no matter how much they drink, they can't hydrate enough. So they'll make stones over time. So I talk about employment, see if they're at risk, if they can't drink enough. I've written some doctors' excuses to please allow them to go to the bathroom when they need so they can really drink enough water. I ask everyone about their employment, their activity level, or any recent changes in activity. So athletes, I see a lot of people with seasonal sports, so golfers, bikers, and runners, where their stones primarily form during the summer, and then they start coming on later parts because they have formed stones when they're competing. Exercising, I always ask about making sure that they're staying well hydrated during these activities, or outdoorsmen who are just outside and they're not drinking enough in the hot weather. And then I usually throw in hobbies just in case if they're strenuous or very high heat. So I think the biggest thing that we do are the dietary component, and that's where most of the data that we'll talk about today lies. So in my opinion, this is the biggest component, and it's where I spend my most time in our clinic visit. So I first like to start off with what have other physicians or providers told you about how to prevent your stones, to get a background of what they know, so I can help expand on some concepts or discuss new concepts to them. I like to ask about all their meals, just to get an idea of what they're eating throughout the day, as well as snacks, just to have a good dietary diary. And then generally, like I said, the biggest focus of the nephrology visit, we go through this every time, see if anything changed. And then I generally pull up the 24-hour urine result that usually a month before I have them do the urine. It'll be on the screen. I'll show them so that what they think they're eating and drinking, I will tell them what they actually took in that day. So we can go over that. And I use it as a quiz just to see how well they're doing or what we need to work on. So over time, they become pretty good at reading their own 24-hour urine tests.
Is that always with the Urolink, or do you after you have it identified, do you just do a standard calcium, sodium?
For our clinic, I always use the Litholink, so I can watch them over time and to see if anything has changed. And right now, I think Freighter's going to try to get away from Litholink because it's been taking, I think at some points I've heard like a month to come back. So we've been having some issues, so we might be going to a new test that will be in different molecule or different reference ranges, but it'll still have the same data. But yeah, we follow these, the same tests, just so we can follow it over time. So So the biggest parts of my dietary history that I take, I want to know about fluid intake, high salt intake, and that's why I ask them how much salt they think they're taking and compare it to what they tell me, and then the litholink or the Eurorisk, because they'll tell me exactly how much they took. The high protein diet, especially meats, I'll ask about how many servings they take and what type of meat or what kind of protein is it based. Is it mainly animal based or plant based? And then high calcium intake. So I'll see how much calcium they think they're taking in. I think the highest we've had at the VA is someone said he was eating like 5 pounds of cheese every couple of days. Because he worked at a restaurant and thought he just would eat cheese. So he made a lot of stones, and we finally figured out he was taking in a couple pounds of cheese a week. And then the biggest one is high oxalate intake. So that's what we focus a lot of time on. The biggest one, spinach, beets, rhubarb, which I found is a very Wisconsin thing. Nuts, beans, chocolate and soy products, and tea. I have the whole list on my in one of the slides, and it's passing around somewhere. But this is the biggest packet that we give out because this is the most common type of stone. And then any supplements. And there's always, the list keeps expanding on supplements. Every year, people are trying newer things. So I'll typically have to look them up online to see what they actually are taking. The biggest thing right now, and it comes every couple years, the green tea smoothies. When I was a resident here, intern, they were a really big fad, and a lot of people went into renal failure with them. But a lot of times people just make spinach, kale, and mix green tea extract into a smoothie. It's a extremely high oxalate load, and it was for weight loss. The problem is that it's such a high oxalate load, they can start making stones or their entire kidney will stone over. And it can actually cause really bad interstitial nephritis to the point that we'll biopsy them and their whole kidney is inflamed. And I've personally seen a couple people go on dialysis for this and not come off. So that I always ask about smoothies. If you see my notes, that's why. Because you'd be surprised, even in the hospital, people will bring in outside food, and I've seen beet smoothies and green tea smoothies come into the hospital. So I'm always asked about this. High dose vitamin C, like I said, breaks primarily into oxalate and can cause oxalate nephrosis. Super greens, that's another class of things I've seen in the last couple of years where people are taking. A lot of these are promoted on podcasts now, and they're sponsored by podcasts sponsor them. And people will take them thinking that they're healthy for them. They're not FDA approved. And then if they form stones, I always like to know, but super greens are one of the big ones, mainly because they're filled with just all the green vegetables and especially spinach. So they make a lot of oxalate-based stones. EG1 is a supplement. It used to be called super greens, but it's another one that it's just a green compound and it's all the green vegetables ground down, and then people are taking them. They usually come in like vats and you just scoop it in. So I see people taking these a lot. Protein-based supplements. Some of them are actually nut-based and peanut-based, so that's just pure oxalate load from the peanuts. But also protein in itself will cause hypercalciuria and make them have stones. And then a lot of beet extracts people will take is a very high oxalate load as well. This is just a small list of the things I see people taking, but it changes every year because all these compounds come out. They're marketed as they're very safe and good for you. And then in the certain subsects of patients, they'll make a lot of stones from them. But I think the big thing is just green tea smoothies in general. I see a lot of patients that take that. So some of the laboratory evaluation that we look at for the metabolics is obviously a chem panel. We look at calcium, albumin, phosphorus, magnesium. Uric acid, I always check if there's a question of a uric acid stone. Sometimes the people don't know, or the patients don't know what stones they're making, so I kind of have to guess. But if I check the uric acid and it's high, it could be a uric acid stone. Typically, I will always check a vitamin D and PTH level. Sometimes people think it's good to take 10,000 units of vitamin D every day. So I've caught a lot of people overdosing on vitamin D, causing their stones. Then obviously our urine studies. So we look at the creatinine, the crystal constituents, so the calcium, oxalate, phosphorus, and uric acid. The question mark of cysteine, it's always in our reports. I've personally never seen a positive one yet, but it's good to know that they look for that. And then we look at supersaturation. So that includes the volume of urine they're making, the pH and the sodium levels, of what they're taking in. And then the inhibitors. So citrate is obviously the big one, magnesium and potassium. So some of the treatments that we use in kidney stone clinic. So like I said, our common goal is to decrease the frequency and size of stone formation. So we have the acute treatment or the acute disease. So obviously we either need to remove the stone or have pain control to get the stone out. So that's usually urology, primary care, and the ER. Where we step in is the prevention. So metabolic evaluation, medications or changes in diet, and then possibly surgery if needed, if the urologist finds something that they need to fix. So I just did the chronic treatments for the calcium-based stones because that's what most of our shared patients have. So our main focuses today will be on dilution, maintaining normal calcium intake, reducing urine calcium excretion, reducing the urine oxalate levels, and increasing urine citrate. So dilutional therapy, I think this is the cornerstone of kidney stone prevention. There's no set amount of fluid that a patient needs to drink. And I think that's the first thing that people question me on when they see me in clinic is, I was told I needed to drink this amount of water and that I wouldn't make kidney stones. I think the biggest, it's patient dependent. So our goal is to get at least 2 to 2.5 liters of urine production. So in some patients, they may have to drink much more than that to get to it. If they're sweating, doing a lot of activity. So this is the first thing we look at when we look at the UroRisk or the LithoLink is to how much urine they actually put in the jug. And they do that all day. They carry around a jug and urinate in it. So it's pretty reliable as to how much they got in. We like to see 2.5 liters. That's usually the goal that I have for patients. However, I think Dr. Wesson's record was 9 liters of urine one day that a guy brought in, but typically it's much lower. And then here, a lot of my patients ask about hydration multipliers. That's the new subsect of this, keeps going forward. That's the new subsect of supplements like the liquid IV sticks, or they're marketed as hydration multipliers. They're mainly just filled with sodium. Some have a lot of vitamin C in it. And I don't like using those in my patients because they actually can cause stones with how much salt is in it. So I just tell them generally water or adding things to the water. Crystal Light is fine, but sodas, everything else, I try to have them limit. But it's mainly water I try to push on the patients. So in the data, the initial urine volume, so we have control, and then obviously the patients who are forming stones. This is data that looked at how much are our average stone formers for their first stone, how much urine they were making. And you can see men, they were making about 1 liter of urine a day. And women, they were making just under 1 liter. So a lot of it has to do with urinary dilution. So we try to push this as much as possible. And then this data is looking at stone reoccurrence rate. So high water intake is on the bottom, and then spontaneous water intake. And you can see over 4 to 6 years, people who really increase their urinary volume tend to make less stones. So this is the cornerstone of my therapy. I try to have them push as much water and fluid as they can, so we can help prevent stones that way. This chart looks at calcium saturation or supersaturation with urine volume. So we can see as we make more urine throughout the day, and this is going up to 7 liters, the relative risk for saturation of calcium oxalate goes down. So our typical stone, a lot of stone formers fall into 1 liter, and they're making the most stones. And then we get into how do we reduce urinary calcium excretion. So typically, we still want our patients having calcium. So I typically will say 1,000 to 1,200 milligrams per day. And it should be taken with meals and not snacks. There's multiple thoughts as to why with meals. It doesn't create the bigger surge in serum calcium levels and that the kidney sees, and then we excrete out in the urine. But also the thought is that the calcium will help bind to oxalate and phosphate, and then we excrete in our feces and not the urine. So I will try to have my patients have all their calcium with their meals if possible, and try to limit it with snacks, so we don't see as many stone forming events. Limiting the sodium in the diet. So I'll typically try to push for about 2,000 milligrams of sodium a day. The EuroRisk and Litholink will tell us exactly how much they took that day. People will think they're on a low sodium diet. Typical American diet's about 4 to 5 grams. The highest I've seen is 12 to 15 in some of my patients. But we do see some patients that actually do a really good job and stay under the 2,000. But I watch all the foods they eat and then ensure to show them the data of their urine. Lowering their protein in the diet, so we try to limit about 1 serving a day. I like to push more fish, chicken, and turkey, so it's less denser meats like the like red meats, so that we just don't have the acid load from the protein to cause the calcium to leak. And then additions of thiazide diuretics. And this can be difficult, like I said, just because they can drop the blood pressure in patients. So I typically will start very low dose and titrate up if possible. And then looking at some of the data. So this is looking at calcium intake and kidney stones. So the lower the calcium, we were at a higher risk for stone formation. Once we get into the normal or higher levels of calcium intake, your risk for stones go down. So a lot of our patients think, well, I'm making calcium stones, I'm just not going to eat calcium. So I try to tell them that the data shows that we need calcium. Obviously, we're going to weaken bones if we don't have calcium in our diet. So I try to push at least 1 to 2 servings with 1 to 2 meals to start with, so that they are eating calcium. And then this graph shows, I hope it shows up okay. Normal calcium and low protein, low salt have a much lower stone reoccurrence over the low calcium diet over time. So this graph is showing calcium excretion in the urine and its relation to the sodium excretion. So the stone formers that are hypercalciuric typically will have a little bit more salt a day. We can increase their urine sodium a lot and then cause stones to form. So typically the millimoles per day, about 100, I usually say is a roughly 2 grams of salt. But if you increase it just by double, your stone risk goes up and your urinary calcium can go very high. So we'll actually see when we go back to our case how that can change, because the guy was watching his salt better. And then calcium excretion with protein intake. So the higher load of protein we have in a day, our urine calcium excretion goes up. So that's why we want to try to prevent high protein diets, which I think are being pushed a lot more these days. So we can actually see more stone formation with high protein diet. So we try to have our patients eat a lower protein diet. And then this is the older data, the original from when thiazides for stone reoccurrence, just showing that the longer acting chlorthalidone showed a lower risk or a lower stone formation risk over placebo. Hydrochlorothiazide used twice a day at 3 years was about the same over placebo. Newer data looked into this, and everyone's asking now. They looked at, it was a little different. This was more you pass the stone. The new data looked at radiographic changes. So there's thoughts of, do we use thiazides a little too much, and does it really help stone reoccurrence? I'll still, if someone has a very high urine calcium, I'll try them on hydrochlorothiazide or chlorthalidone or indapamide. Sorry, it keeps going forward. Just to try to help lower the urinary calcium. But you have to get them to pretty high doses of the drugs, and a lot of times I'll have patients start calling in with orthostatic symptoms. So I'll warn them right away and tell them, if you start having this, stop the med and call my clinic. But there is data to support trying to use it. And then the biggest one, reducing our urine oxalate. So like I said, reviewing all the supplements they take, vitamin C and the food, and then making sure they take enough calcium, or if not, if they can't take calcium or dairy because of lactose intolerant, then we have them take Tums with meals to help bind the oxalate. And this was just a snippet of the very high oxalate foods that was in the packet that I sent around. But a lot of times we'll see people are drinking a lot of teas, instant coffees, soy products are very high in oxalate, milks. What gets a lot of people in trouble in my clinics is they start eating a lot of nuts and nut butters, but there are some fruits within the high oxalate. So that's why I give everyone that packet, just so they can see what foods are higher and lower. And then the last way is increasing urine citrate to help buffer the urine to help prevent stones. So obviously reducing protein in the diet, especially animal-based, will help increase the citrate in the urine. Increasing fruits and vegetables will help with the citrate. So typically I'll tell my patients adding lemon and lime squeezes or the concentrate bottles that you can buy at the store, we'll put that in water and it'll really help. They can add lemonade in to help prevent stones. And then we can actually prescribe citrate tablets. You can pick up Tums and bicarbonate tablets over the counter, but we're using high doses of potassium citrate or calcium citrate to help prevent kidney stones. Well, online now they came out with this Moonstone, which is a very high dose of citrate that Dr. Wesson found, and it's pretty expensive, but for some patients we'll tell them that they can try it if they can afford it, if they don't like the potassium citrate pills, because they can burn. And then this is the evidence that we use potassium citrate. So case citrate dosed over time, this was looking at 3 years, the risk of kidney stones was a lot less than placebo. So putting it all together, so this is coming back to the first slide I showed you. So looking at we look at the urine volume first. So obviously I just used the same one that he was on. We'll go through his. But we look at urine volume. When it gives you this SS, this is just for the calculation in the computer as to what your highest risk is. So this was a high risk calcium oxalate. We want to try to lower this risk in the computer. We're looking at the urine calcium, oxalate compounds, citrate, uric acid, if the patient makes a high uric acid stone burden, the sodium, which I talked about, and then the other one's phosphorus, if we make phosphorus stones, so it'll tell us how much phosphorus they make. Ammonium can kind of help us diagnose an RTA. And then the PCR litholink is the big one. They calculate how much protein they're taking in per kilogram per day. So we try to push this down less than 1 or more if we can to help prevent the high protein load causing the high calcium. There's a lot of compounds in the test. So back to our case. So when I was talking to the patient, like I said, he was unable to take dairy due to his GI issues. So he would take a lot of, he was taking Tums now right before his meals and trying to stop the PRN doses. I looked back in the notes, he was taking up to 3,000 milligrams a couple times a day of Tums just for his stomach. So that's why his first urine calcium was very high. He was also drinking a lot of almond milk, which is just an oxalate load because of all the almonds in it. And like I said, he was taking a lot of PRN Tums. He wasn't taking smoothies. However, when I talked to him, this was one of the big changes, is that when he saw Dr. Wesson, he started drinking protein shakes that were made from peanut butter. So you can see these, you can find them at Costco. They come in huge jugs, and it's called PB protein, and it's from peanuts. So that was something he started changing between when he saw Dr. Wesson and I, about 9 months apart. And then he started taking some vitamin C because he thought it would help him feel better. So the recommendations that I had based off that first urine, because he was only making about 1.5 liters, he needed to push his urine formation more, adding some lemon and lime to the water. He didn't tolerate the citrate tablets, so he was trying to add some lemon and lime to the water, but he had just given his GI issues, he couldn't tolerate the potassium load. He shouldn't be taking Tums outside. Watch the PB protein supplement, stopping vitamin C, and working on lowering his salt. Because in the first 24 hour, like I showed you, he was about 250 millimoles. So that put him at about 5 to 6 grams of salt a day. So he needed to work on that. So his follow-up 24-hour urine. So he actually improved his urine volume. It went from 1.5 to 2.4. So we can see his main risk went down, probably mostly due to his higher volume. But then his oxalate load went up, and that was likely due to all the supplements he was taking, as well as vitamin C. So that's why I consulted him on not taking all of those. His citrate was still lower, but he's going to try pushing other methods if he can't tolerate the citrate. And then he did actually do a pretty good job. He cut down by a couple grams of salt, but he's still kind of high. So I told him to watch the salt. So for follow-up, what we generally do after the initial consult, I'll put in for a 24-hour urine a couple months after I first see them to see how well they retain the knowledge that I had and to see if I can push them even farther. And then we usually space out the 24-hour urines to every year. Because they are very expensive. So I try to minimize how many we do, but we generally get one a year. And then typically we get them about a month before they're supposed to follow up so that we can have the data for clinic. And then every year we generally either urology or the nephrologist will order either a renal ultrasound or a CT just for stone monitoring. So how you can refer, we're through the general nephrology clinic, both here or the VA. If you put one in at the VA, they'll automatically just put them into my clinic because I see all the stone people at the VA now. But you don't have to worry about putting in the 24-hour urine tests. Our nurses will put them into our name, so they'll result in our name. So when they come to clinic, it'll be already there. And then, like I said, it's myself, Dr. Wesson, and Dr. Dahl. I made it just in time for the 1 hour. So any questions? And I really always put this.
Hi, Andrew.
Yeah.
This is Joe Shaker.
Yes.
Great talk. Quick comment. It was a pleasure to meet your parents at the South Shore Marina Fish Fry, and they very proud of you. But I have a question. I sometimes have patients who have calcium phosphate stones, high urinary pH, and low urinary citrate. And my concern about adding citrate is that it will raise the pH and decrease the solubility of calcium phosphate. So how do you deal with that tension between those two opposing factors?
So a lot of times what we'll actually do is, and I've put patients a low phosphate diet, and then I'll actually use like calcium acetate or a different form of our phosphate binders that we use in nephrology clinic to help get it into the feces and not the urine. So we do use calcium-based binders in this practice just because they don't have CKD generally.
Right.
So calcium acetate works, Tums will work, but you do get a little bicarb load from that. So typically I use calcium acetate for those patients.
And you don't try to increase that urinary citrate to normal?
Not with meds. I'll try to use it with like the lemon and lime squeezes or lemonades. I just don't push it with calcium or potassium citrate because it can be a high citrate load to get their pH balance.
Thanks. I mean, it's a problem with the topiramate patients. You know,
That's generally what I
RPA.
see. And I, with the topiramate patients, if they cannot be taken off, I'll try to use calcium acetate
Thank
to
you.
bind the phosphorus. Yeah.
So you had mentioned doing annual radiological follow-up.
Yeah.
Is there a duration at which you say, okay, I think we don't need to?
A couple years. If they're stone free for a couple years, I'll stop. Some of the, even I'll go to every other year urine testing because it can be a burden. But generally we'll watch for the first couple of years with a renal ultrasound.
Why do blacks have fewer stones than whites? And are there other racial and ethnic groups that have limited stone formation?
I'm really not sure. I wish I had that answer. It's in the data, but I'm not sure why.
Hey, this is Joe. Can I comment on that? Yep. There is good data that blacks have lower urinary calcium, Jay. And that's true even in their patients with primary hyperpara, which makes use of the calcium to creatinine clearance ratio difficult in blacks. So, I mean, I don't know if that's the reason, but they definitely do.
Don't blacks probably eat less dairy?
I don't think it's that simple, Jay. Norman Bell, I think, published that data decades ago about lower urinary calcium in blacks, but I don't know what the reason is. Hey, Andrew, can I ask another question?
Yeah.
Are you using the genetic counselors now have a hypercalciuria stone panel? Are you sending many patients for that yet?
I have not. The only genetic testing we're doing right now in our kidney clinics is the Renasite, and that's looking at primarily renal disorders. No, I have not personally sent any of those. I can ask Dr. Wesson to see if he's sent any.
Yeah, thanks. Sometimes I have a patient who I wonder if they have a NAPI2A mutation where they have a lowish phosphate, a highish 125D, a lowish PTH, and hypercalciuria. And I've asked them to do that on a couple occasions, but
I'll have to look into that. Thank you.
But yeah, I just know they're doing it. I haven't used the panel yet.
Yeah, great talk.
Well,
Thank you. I'm Elena Glindico. I'm new faculty. So I'm going to be doing bariatric clinic. And obviously in bariatrics, we push a lot of high protein
Yes.
diet. And obviously they're high risk for.
And they can't drink a lot. That's the problem.
Exactly.
Is they have
And
to
then
have
the
high
absorption.
protein load. Yeah.
Is there a study showing, are we that into, are we really supposed to push that high protein diet, or is there additional risk? Am I not a factor? Or
I'm
is
not
there
sure.
something that we
I'm
need to-
really not sure. I think the biggest thing is helping minimize it, but they need to be eating certain things. So I try to help them as best I can. But I've seen some after Whipple even too for cancer that they just keep making stones, and it's very hard.
So in my weight management clinic, I sometimes prescribe topiramate, and
Mm-hmm.
I usually keep the dose relatively low, but I was wondering if there's a threshold or at which the risk of kidney stone.
I'm not sure if there's a
increases.
threshold of dose, but I follow the urine pH.
Oh.
I'll just get a UA because it's a lot cheaper than the big study and see how far their urine pH is going down just on a UA. But if I see, that's why I look, if I see topiramate patients come in, I check how far their urine pH has gone down.
And what would be a threshold for saying, okay, that?
I've seen some into the 7s, so they can really alkalinize the urine. The hard thing is can they stop? And I have a lot of pediatric patients that have been on it that's the only med that works. And then we have to use other methods if we can, like calcium acetate or watching what's in the diet.
Right, but for the weight management,
Yeah.
that
Weight
can
management,
be
we
one
can
of the
stop.
pieces of the puzzle that we
Yeah.
Yeah.
Okay, thank you.
Mm-hmm.
Seems like a lot of patients can't stop either. Migraine patients, it seems like,
Yes.
that you just can't get them off. Thanks, Andrew. That was terrific.
Yeah, anytime. Thank you. Well, thank you for having me. If you have anything else, always feel free to email me or reach out. Thanks.
Thank
Thank you.
Sure, yeah. Let's resume.
Staff are out.
Yeah.